Hi, everyone. Oh, my goodness. Oh, just one second, putting the Instagram. So this is Dr. Isabelle Amigues, your friendly rheumatologist. And today we're talking about what it means to have a positive ANA and if you can have a positive ANA without having a disease. And this question actually comes from this exact question. Can you have a positive RNA polymerase free and not have systemic sclerosis? Or can you have a weak positive? As there is so much crossover between autoimmune issues, it is likely to be overlooked. Okay, so such a good question, right? So I think what we're going to discuss is how and why we check antibodies, and then what we do with it and what it means and how we make diagnosis, right? So I'm Dr. Isabelle Amigues, your friendly rheumatologist. I work in Denver and Colorado. I do a lot of telehealth, and I have the first and only direct care rheumatology in Colorado. And if you are looking for a rheumatologist, I would love to be yours. Now, we're going to talk about antibodies, so autoantibodies. So, and let's take an example which happens so often. So very often in my practice, either they come to me because they have been referred to me, or I have colleagues that call me and are wondering, hey, this is a positive, there's this patient, I checked an ANA because she had some fatigue, or positive, or ANA is positive, what do I do? In the case of this commenter, the comment that I had, it was literally saying, hey, I have this positive RNA polymerase free. Does that mean, so this antibody is associated with scleroderma, does that mean that I have scleroderma? And so very often what I have to explain to patients is that we do not make a diagnosis only based on antibodies, because you need to have more than just the antibody to have a condition. So we're going to take the example of the ANA because we have a lot of studies on the ANA. So if you were, so I'm going to give you the study and I'm going to tell you what it means. So it's a study, basically we looked at the army, so veterans, and when you go to the army, you can give some blood and you are healthy. That's one of the things that you have to be healthy. So you're healthy. We know exactly what disease you have. You're followed by physicians. So we do that and we can take blood work. And what happened is that we actually later on, there were some studies that looked at patients who had developed lupus in this case, or autoimmune disorder. And we looked at their antibodies and we found that the autoantibodies were positive before that they had any symptoms. So the thought process, and we cannot prove this because it's basically when it's retrospective, you can only say this is my hypothesis, and honestly, it really makes sense. But the hypothesis is that you first develop autoantibody, and then later on, there's something else that happens that triggers the actual damage to the organ. And it's when you have damage to the organ that you develop that we can say that you have this autoimmune or autoimmune disorder. In the case of this ANA and then lupus, we know that you first have an antibody that recognizes the nuclear, so that's the ANA, right? And that because you have this, for some patients, this is going to spread. So you're going to have more and more antibody. And as you get more and more antibody, that can actually lead to damage, inflammation of the organ, and then ultimately damage of the organs. And it's when you have damage of the organs that you can say this is lupus, right? And so our job as rheumatologists is to get to act at the earliest place of this autoimmune process, basically. And so you would tell me, so you have antibody and then later on you're developing lupus. Why don't you want to treat me right away? The problem is that you can have an antibody without any autoimmune disorder. And so when we did this study, not me, I wasn't involved in that particular study, but when that study was done in the veterans, what happened is that they looked only at patients who had developed lupus, and then they looked back at how many of them had positive antibody before, right? in the general population, and we have studies looking at that, we know that you can have antibodies that are positive without any sort of autoimmune disorder. And so when we get an antibody, when we're being evaluated for an antibody, the thing is that you should actually know what you're going to do with this. So I'm going to just backtrack a little bit here just to talk about, to answer the first question that I was saying, which is, if you have this antibody, why can't you act right away? Well, there are studies that are looking at patients with a positive ANA. Can you prevent that? Or positive CCP, which is even more specific for rheumatoid arthritis in that case. They look at giving plaquenil, hydroxychloroquine in patients with this just positive CCP without any other symptoms of rheumatoid arthritis. And we don't see any difference. It doesn't change, right? So why give you a medication if it's not going to change the outcome? So that's number one. The second is that we can always treat. There's no cure per se just yet. It might happen, honestly. I do think in my lifetime it will happen. We will have cure for rheumatoid arthritis. We will have cure for lupus. I'm very excited because I know it will happen. But for now, we can just put our patient, it's pretty remarkable. We can put our patient in remission. And with the treatments we have, we can put our patients in remission. So personally, I don't necessarily see that there is a benefit in putting someone on a medication with just a positive ANA or positive RNA polymerase III or positive SCL70 or positive whatever, right? Like a positive antibody, autoantibody, because if they haven't yet developed any disease, right? They just have this antibody. It's just a marker. It doesn't mean anything. It doesn't necessarily mean that you're going to develop a full-blown autoimmune disorder. And also we can treat that. So that's number one. Then number two is, how do we make a diagnosis of autoimmune? Definitely not just with an autoantibody. So again, you can have an autoantibody, and we know that the general healthy population can have positive autoantibody and have zero symptom whatsoever, even if you were to do like all the scans in the whole world, not just clinical exam, right? Zero symptom. And then also the thing that's really important is that if you have zero symptom, even if I were to tell you you have lupus, or which I would not say, but let's say someone says, oh, you have a positive antibody, this is an ANA or SMIF or dsDNA, you have lupus, and you have zero organ damage. Are you going to actually go on a medication? Like that's the question. Some people would argue maybe you could be on a plaquenil hydroxychloroquine. And personally, the way I think about this is that if you have antibodies, autoantibodies, and that are high, not low titers, but high titers, right? And that you have a family history of autoimmune disorder, then maybe I will put it, because the return on the investment, if I give you plaquenil, there is really a risk and a benefit in that case of not developing full autoimmune disorder, because we know that you have a family history. And so you have a family history plus autoantibody, it would make more sense to put you on something. Now, if you have even like the slightest joint pain and you have autoantibody, then I might actually say, okay, well, let's try it and let's see if you're going to feel better, right? But I wouldn't call you autoimmune disorder. I would say maybe you have an undifferentiated, maybe we are at the beginning of very early autoimmune. But I think that that's really, really, really important to realize that yes, autoantibodies come much earlier, sometimes not so much, but they can come earlier than the actual disease. And that's the process that we see, right? It's first autoantibody, first something that triggered an autoimmune response, then an autoantibody, then the autoantibody, there's what we call the epitope spreading, so there's more of them. And then later on, there is affection, like it affects the organ, and that, can cause organ damage. And that's when we say you have an autoimmune disease. And realize that those autoantibody can be present in a healthy population, which means that not everyone that has an autoantibody has an autoimmune disorder. Okay. And so I would argue for this question, I would say for this question, because that is a very important question. Can you have a positive RNA polymerase free and not have systemic sclerosis? You have to realize that when they are tested, those antibodies are tested in populations mostly who have the disease. And then we test it in the people who don't have the disease, and we say, okay, in 95% of the cases, if it's after this level, then patients, there is more chance of it being associated with disease, but there is 5% of chance that it's not associated with a disease, right? That's the Gauss curve, the normal curve, right? And so in this case, that's what I want to say is that, well, if you have an RNA polymerase free, why? And that is the most important thing. Why did they check that? Is it because you have some kidney involvement? Is it because you have some sign of scleroderma? Is it because you have Raynaud's phenomenon, right? It's when your fingers become white, and maybe it's one or two, maybe all of them, but you have a clear demarcation between the white and the not white, and then it can become red, blue, and then red. That's Raynaud's phenomenon, and it's actually pretty common. I have it, and I don't have an autoimmune disorder, and I've had it for many, many years. But then if I were to check for whatever reason, I don't want us to check a positive. I don't want to check any autoantibodies on me, because I'm like, well, I have no symptoms except Raynaud that has been there forever, and it's really not a problem. But if I were to develop some joint pain, I probably would check, and I would be like, okay, there's Raynaud's phenomenon, there is inflammatory arthritis, and then there's a positive ANA or positive whatever, an autoantibody, then maybe there is an autoimmune disorder, right? The way we make a diagnosis of autoimmune disorder is mostly with clinical symptoms. So Raynaud's phenomenon, patchy hair loss, skin tightening, GERD, shortness of breath, what else? Skin rashes, like the Raynaud that I was saying, that, we would be thinking like skin tightness. Okay, can this be scleroderma? Sometimes you don't have positive autoantibody, and we're not going to say you don't have scleroderma if you have all of those symptoms that are typical of scleroderma, right? And so I think that that's really important. We put so much weight into those autoantibodies when they can confirm that you have an autoimmune disorder. And personally, I love it when I'm like, okay, I think this is this. I think this is rheumatoid arthritis, or I think this is lupus, or I think this is scleroderma. And then there's a positive autoantibody that makes me feel really good, because I'm like, okay, yeah, great. I made a diagnosis and it's confirmed. Great. But honestly, like sometimes you do not have those autoantibody, and it's really the art of being a rheumatologist. Okay, so yes, you absolutely can have a positive autoantibody and have no autoimmune condition whatsoever. That said, you've got to double check. Do you have family history of autoimmune? Because if you do, then you're more at risk. The second is, are you taking any drugs? Like, could there be any of the medication that you're on that caused that? And then the third one is, well, why did you check this autoantibody? Is it because you had symptoms and you don't realize? And I think that that's something that you have to talk with the physician that ordered those labs, okay? I hope this was helpful. Let me look. Hi, Nicole. Hi, AIBIPOC, and then 2002. Such a pleasure. Again, if you guys are watching the replay, press or write hashtag replay. And I hope this was very helpful. And then I will see you next week. And if you could subscribe on YouTube on the Rheumatology 101 by Dr. Amigues, AMIGUES, I would be so grateful. I'm trying to reach 1,000 subscribers, which I think would be really cool, because I think this has not been 1 year yet that we are doing those. Have a wonderful day. Take care, everyone. Bye-bye.